I am Dr. Yogesh Harwani, Hospital, Dr. Vivek Tam, my team. I welcome all of you to fourth clinic of Advanced Gastro Summit, which is jointly organized by physicians of Ahmedabad Association and Noble Gastro Hospital. I am very pleased and it's an honorable moment that Dr. Ajay Duseja is with us today to discuss on non-alcoholic steatohepatitis and fatty liver. Before that, I would like to introduce our moderators. Our moderators for today will be Dr. Ajay Prajapati and Dr. Both are working together for diabetes. They treat diabetes as well as they both are metabolic physicians. So they will also and NASH, non-alcoholic steatohepatitis. Association of Physicians of Ahmedabad, Association of Ahmedabad Surgeons with us. So I would like to request Dr. Ajay Bhai to introduce our chair session with the introduction of Dr. Ajay Duseja, sir.
Thank you, Dr. Irvani. Am I audible?
Yes, yes.
Okay. Thank you, Dr. Irvani, for the kind introduction and giving us opportunity to take in part in this wonderful session. We have a wonderful session about non-alcoholic fatty liver disease in next 1 hour. For this session, we have a honorable speaker on dais, and I will invite Dr. Ketan Joshi, Secretary of APG, and Dr. Milind is a senior physician of Ahmedabad. So it's I will request both chairperson to take a session, and we can go ahead. Dr. Ketan Joshi, Dr. Milind. Dr. Milind, sir, are you here?
Milind sir, you're on mute.
Okay. Good evening, sir. Am I audible, sir?
Yes, now audible.
Yes. Good evening, all our teachers, Professor Ajay Duseja, sir, Dr. Yogesh Harwani, sir, and APA as well as physician members all across India. It is my privilege to welcome you all on this webinar. So, as Dr. Harwani sir has said that Dr. Ajay Duseja sir is a professor of gastroenterohepatology, PI Chandhigarh, and I will request him to begin his lecture. Thank you very much, sir.
Okay, can I start now?
Yes, sir. Yes, sir.
Let me share my screen first, and you need to tell me if you can see my slides in the slideshow mode. Are these there?
Yes.
Yes, sir.
Yes, sir.
Okay, and they are moving, right?
Yes,
they are moving.
So, good evening, everyone. And I think at the outset, my sincere thanks to Dr. Yogesh Harwani, who's I learned is the organizing secretary for all this ongoing CME series, and also my sincere thanks. I learned that the course director is Professor Mahesh Goenka, and my again gratitude to the API Ahmedabad and the Noble Hospital Ahmedabad and all the members of the organizing committee for giving me this opportunity to be part of this ongoing CME series. And I must confess, I had sent this flyer to some of my colleagues, and everybody appreciated the the kind of practical topics which you all have kept for this evening series of CME. So my job today is to tell you about about the practical approach to a patient who's incidentally found to have fatty liver on ultrasound and is a non-alcoholic. So that is the job which is assigned to me. So I'll take around 45 to 50 minutes to go through this approach, and then maybe 10-15 minutes we can have some discussion and questions. And I will request both the moderators and the chairpersons to keep looking at the chat box, and maybe they can then put me the questions and we can have a combined discussion, right? So let me begin first. I mean, I learned that the predominant audience here is physicians, though there are some gastroenterologists and hepatologists also have joined in. But then let me start with, there's an ongoing debate which is happening, I would say, or I would say it is becoming a little controversial also, that the terminology which you should be following, should it be NAFLD, which is non-alcoholic fatty liver disease, which we have been following for now decades, or it should be what we call the metabolic dysfunction associated fatty liver disease, which is, they call it as MAFLD, right? So this is because, we know that non-alcoholic fatty liver disease is considered as a hepatic manifestation of metabolic syndrome. And as physicians, you all understand what metabolic syndrome is. So that is why, with NAFLD, it is thought to be a definition of exclusion, which means that you have to exclude alcohol, you have to exclude, other causes of steatosis and rise in transaminases before you make a diagnosis of NAFLD. But with NAFLD, what they are suggesting is that you don't need anything, no exclusion. This is a positive diagnosis. And what you need is just fat on the liver, fat in the liver, which can be evident either on ultrasound or any other imaging, or on histology, or any, even for that matter, even biomarkers. And if you have overweight or obesity, and Asians, we define it as, say, 23 or more as overweight, or if you have diabetes, either one of the two, you can make a diagnosis of so-called MAFLD, right? And if none of these are there, no diabetes, no overweight or obesity, then you need to have these two metabolic risk factors. And the important ones are, these four are again the components of metabolic syndrome. And the other three are that they have taken pre-diabetes, HOMA value, and CRP also. So if you have two or more, I think, of these metabolic risk factors, you can still make a diagnosis of MAFLD. Having said that, I'll not elaborate much on that, because as I said, there's an ongoing debate and there's a lot of rebuttal which has happened towards this changing nomenclature or changing terminology. And many of us actually believe that this is creating more of confusion, and this is probably premature, to change this terminology. And as an editorial, we suggested this, and there have been various other papers on this aspect. And so for today, and till it is all accepted, we will stick to the older terminology, or I would say the current terminology of NAFLD, which is non-alcoholic fatty liver disease, and we will no more be discussing about the MAFLD. So when we talk about NAFLD, I think the first thing which you need to understand is that this is a spectrum, which means patient can just have fat in the liver, which is known as simple steatosis, or a better terminology is non-alcoholic fatty liver, or NAFL. And a percentage of these patients will progress on to have inflammation with or without fibrosis. And that is the term which we use for so-called NASH, or non-alcoholic steatohepatitis. So amongst the two, the NAFL and NASH, NASH is a progressive form of fatty liver disease, and it can progress on to cirrhosis and liver cancer and lead on to all the complications of, decompensation and various other this thing. But the important thing what we also need to realize is that NAFLD is, as I said, a hepatic manifestation of metabolic syndrome. So people do have associated, various other metabolic issues. And if you look at the causes of deaths in patients with fatty liver disease, it is not liver disease, but it is the cardiovascular disease followed by malignancy, and then comes the liver. So I think when you're looking at a patient with fatty liver disease, we need to have so-called a holistic approach, and you should also look at the other systems rather than focusing only on the liver. Now let me start with a case, and as I said, then we will discuss about the practical approach in managing these patients with fatty liver disease. So this gentleman, 51 years old, non-alcoholic, non-smoker, had history of diabetes and hypertension for 10 years, and he was on oral drugs for both. his average body weight was around 70 to 75 kg in last 10 years. And this is very, very important that you must ask your patient about the average body weight in last 10 years or 5 years, because, you know, especially with the onset of high fibrosis or cirrhosis, many of these patients, you know, they tend to lose weight. And if you look at their current weight, it may not really qualify to be called as overweight or obese. But if you check their older weight, I think they may have been obese or overweight. So it's very important, you know, to check for the average body weight in last 5 to 10 years. So he came with incidental, you know, elevation of liver enzymes. And on examination, he was normotensive. As I said, he was on drugs. He had a weight of 70 kg and then the BMI of 24.8. And as I said, 23 is the cutoff for Asians and Indians, which define it as, you know, overweight, and up to 25 is taken as overweight, 25 to 30 is taken as class 1 obesity, and more than 30 is taken as class 2 obesity. He had a waist circumference of 97 centimeter. Again, for Asians, the cutoff taken is 90 centimeter for males and 80 centimeter for females. So he was centrally also obese. There was no organomegaly, no ascites, and rest of the system was all unremarkable. And the ultrasound had shown, you know, moderate steatosis, and rest everything was normal. Now, what is your provisional diagnosis in this gentleman who has come to you with elevated liver enzymes and has fat in the liver? Will you call it as NAFLD or will you call it as NASH? There's always a tendency to call these patients as NASH because they have elevated ALT. But as I said, this practice should be discouraged. Why? Because NASH, when we say, is actually a histological diagnosis, which means that in a patient with NASH, in addition to fat in the liver, you and lobular inflammation, you also have to show the presence of the hepatocytic injury, which is evident by the ballooning of hepatocytes and with or without, you know, Mallory hyaline. And this, in addition, these patients can also have fibrosis. So when we say NASH, it can be fibrotic NASH, which is with fibrosis, or it can be a non-fibrotic NASH where only steatosis, lobular inflammation, and ballooning is there. And I'm sure you all understand that it is not possible on any imaging modality to, you know, diagnose, you know, ballooning or Mallory hyaline, or for that matter, lobular inflammation. So ALT is a poor, you know, surrogate marker for inflammation. We will come down to that, but then you can have elevated ALT and still the biopsy may not show you NASH. On the other hand, you can have NASH and the ALT may not be elevated. So don't make the diagnosis of NASH just based on the elevated ALT. Okay. So now, before I go on to this, the you know, discussion on this case further, let me tell you about the magnitude of this problem. Why are we discussing fatty liver so often these days, and why it has become a something like epidemic? Is because of very high prevalence of, you know, this disease entity in general population, number one. And the general population, when I say, I think we always look at this meta-analytic study from Zubair Yunusi, which actually showed that in South America, it was around 30%, Middle East 31%, Asia was not far behind by 27% in general population. So when we say general population, which means otherwise healthy people, and you just do their ultrasounds and you find fatty liver. But if you look at the, you know, the special groups or the high risk groups, for example, diabetics, those with obesity, those with metabolic syndrome, I think the prevalence would be much, much higher. Now, what is the scenario in India? Again, I think leave the rural part. There's one study from rural part of West Bengal which said 9%, but otherwise in the in the urban part of India, the prevalence is usually around, say, 16 to 20% to up to maybe 50 or 53%. This is our own data where we looked at around 1,000, you know, blood donors at the institute, and we found that 53% of them actually had fatty liver on ultrasound. So these are alarming figures, but then only fat, as I said, may or may not be relevant. More relevant is that how many of them have what we call the significant disease. And significant disease, when I said, we define it by calling it as NASH. So NASH, as I said, is a histological diagnosis. So this is one study from the ILBS, the Institute of Liver and Biliary Sciences, New Delhi, and where this is a data of around 1,000 liver biopsies over around 6 years. And what they found was that the NASH, which was defined by the prevalence of, the NAS score, we call it. NAS is the NAFLD activity score, which is nothing but based on your steatosis, lobular inflammation, and ballooning. It was seen in around 60% of people, which is quite a high figure. And again, if you look at the fibrotic NASH, which means the presence of fibrosis, the significant fibrosis, we define it by F2 or more. So it was again seen in around 60% F2 or more, and 15% of these patients actually had cirrhosis on liver biopsy, which means F4 fibrosis. This is the data of an ongoing study in India, which we call it as ICON-D. ICON-D is an Indian consortium on non-alcoholic fatty liver disease, and this is a multi-center study which we are, looking at as a principal investigator at PGI. But then, as I said, there are around 37 centers in this, all over the country. The centers are participating, and we did an interim analysis recently of around 4,000 patients, and what we found was that around 45% of them had elevated ALT. But then, as I said, ALT is not a good marker, for NASH. So we looked at the FibroScan data on them, which was available in around 2,500 people, and as I said, the significant fibrosis is defined as F2 or more on histology, and on FibroScan, we define it by value of LSM, or the liver stiffness measurement, of around 8 or more kilopascals, and that was seen in around 36%, people. Again, very high figure. And overall, around 11% of them had LSM more than 12.5, which is taken as a cutoff for cirrhosis. So I think, again, very high prevalence of, these are all people who are just walking to your clinic with elevated liver enzymes and fatty liver. And remember, and mind it, I think 10% or 15% of them turning out to be having cirrhosis, and around 40% of them turning out to be having significant fibrosis, which are alarming, figures. Now, coming back to the case. So as I said, I think this is the kind of presentation which he had. He was incidental elevation of enzymes, fatty liver. He was obese. He was centrally obese and had fatty liver on this. So how should you know, what should be your approach in these kind of patients? And I think if you really wanted to get into the details, I think this is our position paper from the Indian National Association for Study of Liver in ASL. And this we had written around, 5 years back. And this actually will give you all the details of the practical approach. But let me now briefly tell you about that. How should we be approaching our patients with fatty liver who are incidentally directed? So what we follow is known as a stepwise approach, which means that we have to go step by step. And remember in the beginning that no two patients of fatty liver may be same. And more so when we say this, I think age is a very important, factor. And we keep saying this in most of our meetings, that a 20 years old boy with fatty liver is absolutely different from a 60 years old postmenopausal lady. So I think the severity of fatty liver disease is different. One, that lady could be a cirrhotic, whereas that boy of 20 years could just be having NAFL or simple steatosis. So a stepwise approach is very, very important. Only then you can, assess the severity of the disease, and ultimately, our aim of all of us is basically to treat our patients well. So unless you make a correct diagnosis, I think the treatment, gets affected. So the first step is, as I said, you need to exclude the causes of, other causes of steatosis and elevated liver enzymes. So always ask for history of alcohol and other causes, which we will discuss. Now, when you ask about the history of alcohol, I think what you need to, remember is that I think in India, and this is the ASLD, recommendation which I have put up, but in India, I think 2 small drinks a day, which is 30 ml. And 30 ml of drink contains around 10 gram of alcohol. So around 10 gram of alcohol into 2, which means 20 gram of day if somebody is taking. And if he's having fatty liver disease and he has metabolic syndrome components, I think we can still call it as NAFLD. But anybody who's taking more than that, we don't take it as NAFLD, and then he will go into the category of maybe alcoholic liver disease. So that is, the cutoff of alcohol, what we use. And then for the beer and for the wine, I think cutoffs, you can have the equivalent cutoffs, and maybe we can can discuss that during the discussion time. The other causes which, other than alcohol, which need to be excluded in the histories in our setup, hepatitis C at least is very common in our part of the country, in Punjab and Chandhigarh. I think so. Hepatitis C, especially genotype 3, is very notorious in causing what's so-called hepatic steatosis. So always, viral markers are part and parcel of, any patient who's coming to you with fatty liver. Always ask for drugs. Corticosteroids are used for so many diseases. And I'm pretty sure as physicians, I think you must be using it in your clinical practice very often. So corticosteroids tend to, cause weight gain, and they tend to cause fatty liver. So very, very important to know whether there are drugs causing steatosis. The other common drugs are the methotrexate. A lot of people, because of the rheumatological disorders, they do take, methotrexate. And methotrexate is not only notorious in causing fatty liver, but also notorious in causing fibrosis in the liver. So it's very, very important, to take that history. Patients with ladies who have been operated for CA breast and are on tamoxifen, again can have fatty liver, and some of the, other drugs like amiodarone and all can also cause. But then also we need to remember that there are various other diseases. I think you need to keep in mind, and all fatty liver are not NAFLD or what we call the metabolic syndrome associated fatty liver disease. For example, anybody who has tuberculosis, anybody who has Wilson's disease can have hyperechoic or a bright liver which looks like fatty liver, but then the cause here is probably a disease, a secondary cause which is causing fatty liver rather than the primary hepatic steatosis, which we consider it to be secondary to metabolic syndrome. After that, once you have excluded all these causes, the next step is, to look at the presence of metabolic syndrome. Now, why metabolic syndrome is important? I think, as I said, NAFLD is considered as a hepatic manifestation of metabolic syndrome. And what is metabolic syndrome? I don't think I need to tell all this to the audience, because you're all physicians and we define metabolic syndrome, by various criteria. But the common criteria which are used are the ATP III criteria and the IDF, or the International, Diabetes Federation criteria. And, they take 5 components into, consideration. And important ones are the central obesity. And I told you the cutoff for Indians, 90 and 80 centimeters male and females, blood pressure, blood sugar more than 100, or somebody is already a diabetic, triglycerides 150, and low HDL 40 as a cutoff in males and 50 in females. So anybody who has 3 or more components of metabolic risk factors, you call it as metabolic syndrome. And our patient, if you remember, was obese, was centrally obese, means central obesity, was diabetic, was hypertensive. So which means 3 components were there. So he definitely had metabolic syndrome. So now, first, again, let me tell you about the magnitude of metabolic syndrome. How common is metabolic syndrome in fatty liver disease? I think, again, I think a lot of studies are available. Smaller studies are there, but then again, I'm just showing you this large data of ours, which is an ICON-D data, which I said. So we had information of around 3,500 people about metabolic risk factors, and metabolic syndrome, which was defined by 3 or more metabolic risk factors, were present in around 43% of people. And our earlier data has also suggested that around 50% of patients with fatty liver would have metabolic syndromes, which means all will not have metabolic syndrome. But then if you look at the various, components of metabolic syndrome, at least one risk factor is seen in majority, and in our data this was seen in around 93% of people. So there are only 7 to 10% of patients with fatty liver disease who will not have even a single metabolic risk factor accounting for fatty liver disease. So majority would have at least one component. And what is the commonest component? Commonest is the central obesity. So this was seen in our data in around 83% of people, but then followed by others. So I think anybody who's centrally obese coming to you with fatty liver, I mean, without doing an ultrasound, probably you can make a diagnosis that probably he is nothing but NAFLD. But then, as I said, you need to exclude various other causes before you make a diagnosis of, NAFLD. So now coming to the importance of metabolic syndrome, one is that it is very commonly associated with fatty liver disease. But the second most common reason is that the NAFLD and metabolic syndrome, if you look at the data, metabolic syndrome presence and the number of risk factors or number of metabolic risk factors would also determine the severity of fatty liver disease. More the components of metabolic syndrome, more is the severity. When we say severity, which means more of NASH and more of fibrosis in the liver. And this one particular study actually showed that as the components of metabolic syndrome went up, your severity or hepatic fibrosis or hepatocytic injury went up. And this is again a very recent study from the Vasia Kaval's group from US, and what they again showed that as the number of components of metabolic syndrome like diabetes, hypertension, dyslipidemia, they increased, your risk of having cirrhosis and HCC both went up. So it is actually very important to look at the components of metabolic syndrome, because this determines your severity of disease, to the extent that your risk of having HCC, your risk of having cirrhosis goes up as the number of components of metabolic syndrome they go up. Finally, I think again, if you look at the American recommendations and even our nasal recommendations, presence of metabolic syndrome can be taken as one indication for doing a liver biopsy, because as I said, this is related to the severity, and you tend to do liver biopsy only in those patients where you are thinking or presuming that they could have a severe disease, which is NASH, with or without fibrosis. So we'll come down to that later, but let me now tell you another concept which is very relevant in our Indian context, and maybe more in southern India, less in the northern India like our place. But then there is a concept which came many years back from India, an entity called lean NASH, or lean NAFLD you can call it. So what are these lean NASHs? Basically, these are the patients with fatty liver disease who do not have overweight or obesity. There are some deficiencies in this definition because it doesn't take into account the central obesity and the various other things, but or other metabolic risk factors. They just look at the BMI. So anybody who's not overweight and obese, you can call it as lean NAFLD. But then in our practice here in North India, and this is again our ICON D data, as I said, 4,000 patients, the lean NAFLD was seen only in around 10-11%. And this is our experience here also. I think we can have more discussion on this. So around 10% of people would not have overweight or obesity, still have fat in the liver. Though this is not considered as one of the components of metabolic syndrome, but the defining definition for lean NASH is based on the BMI. So what is this lean NAFLD then if they do not have obesity? So what is the pathophysiology of fatty liver disease in them? I think it's a subject by itself, but let me just give you a brief overview that people have compared the lean NAFLD with healthy controls, and they have found that even though they are lean as per the BMI definition, they are still older and they still have higher BMI in comparison to the healthy controls. And they still have higher components of metabolic syndrome as compared to the healthy controls. Also, there are some genetic influences in fatty liver disease, and one of the gene polymorphisms which is very commonly associated with fatty liver disease is known as a PNPLA3 polymorphism. And this is again has been found to be more in lean people as compared to the healthy subjects. So then and again, if you look at the insulin resistance, I mean, again, the pathogenesis of fatty liver disease, what we understand today is that the central pathogenesis is nothing but insulin resistance. So when people have compared lean NASH versus healthy controls, lean NAFLD still had higher HOMA values and higher prevalence of insulin resistance in comparison to the healthy controls. So major pathogenic mechanism even in lean NAFLD is nothing but insulin resistance, and there are various other thoughts of pathogenesis, including, as I said, gene polymorphisms, gut microbiota, iron overload, and various other things. Then people have also compared, obese versus the lean NAFLD. So I'll not go into the details, but what you should remember is that major emphasis we are putting today is on the assessment of severity of liver disease, and in general, lean people would have milder disease or less severe disease, which means less of NASH, less of fibrosis in comparison to the obese people. So I think if somebody asks you about the natural history, I think probably the lean probably would have, even though they are metabolically not healthy, but still I think in comparison to the obese people, their disease is probably milder. So let me go further now, and let's go on to the stepwise approach which we are discussing today. So the next step is, the once you've done the secondary causes and you've done the metabolic syndrome, obesity and all that, I think you need to look at the transaminases or the AST/ALT values in all your patients with fatty liver disease, not to make the diagnosis of NASH, which I said in the beginning that based on the ALT, you should not call them as NASH. But this is to know any associated diseases which might happen with, fatty liver disease. Fatty liver disease, we discussed, is so common. I mean, in a given population, even 30, 40%, 50% of the population may have fatty liver disease. So that doesn't prevent them from having any other disease. For example, anybody with NAFLD could have associated hepatitis B infection, hepatitis C infection, and that could be the reason, for causing rise in transaminases, and fatty liver could just be a bystander. So I think it's very important to look for other causes of rise in transaminases before you say that the rise in transaminases is happening because of fatty liver disease and not because of something else. So what are these causes? I think these are very common things which I'm pretty sure that you would be doing in your clinical practice. Always look for viral markers. Hepatitis and B and C need to be excluded. Autoimmune, in a given situation, suppose there's a young female has another autoimmune disease, say SLE or rheumatoid or anything else, and comes to you with elevated liver enzymes, even if the ultrasound is showing you fatty liver, I think you must do the autoimmune markers, do the IgG levels, try to rule out autoimmune hepatitis before you say that the elevation of liver enzymes is happening because of, fatty liver disease. Similarly, if there's a young, person who's coming to you with elevated enzymes, fatty liver, as I said, the Wilson disease, if needs to be excluded, less than 45 years of age, and more than 45 years of age, if you're keeping, which is an uncommon possibility, but iron overload sometime can, cause that, so iron profile. And uncommonly, we have seen celiac disease to be associated with rise in transaminases and fatty liver. So if there is a clinical setting, I think you also probably need to exclude that. So, but again, I think let me emphasize here by making the same point which I made in the beginning, that don't make your diagnosis of NASH just based on the elevated ALT. Because this is one study, little older, but which I picked up, and this again we keep showing in most of our meetings, is that there's a very poor correlation of liver histology with the ALT levels in patients with fatty liver disease. You can have normal ALT level as shown in this study and still having high fibrosis, bridging fibrosis and cirrhosis. On the other hand, you can have elevated liver and ALT and there may not be any severe disease. So I think vice versa is true. So I think don't make the diagnosis of NASH, as I said, based on the raised ALT. So finally, I think going to the further step is the final, as I said, all fatty liver disease are not same. So you need to categorize these patients into NASH, and within the NASH, you need to categorize whether they are fibrotic NASH. So a lot of non-invasive assessment is usually recommended in these people, depending upon the availability at your place or your center. You may not do everything, but whatever is possible, must always try to categorize your patients into, as per the severity. And as I said, your treatment again would be dependent on that. So there are certain simple things which you can do at your setup as physicians, and then there are certain complicated things which probably could be possible even in tertiary care centers. So I think age, obviously, as I said, is a very important, parameter. So as I said, young male versus an old menopausal lady, I think they are not same. Female menopausal, as I said. Then other simple things which you can look at your places, simple AST/ALT values and the AST/ALT ratio. The AST and ALT in any particular liver disease usually go hand in hand, and ALT is usually more than ALT, usually in most of the diseases, right? But then, except few diseases like Wilsonian and alcoholic hepatitis. So in others, once the AST starts becoming more than ALT and the ratio becomes more than 1, you start thinking about, increasing fibrosis and cirrhosis. So this is a very common, blood bedside, test, which would be available in most of your patients. Just look at the AST/ALT ratio. If AST is more than ALT, I think be a little cautious. Try to exclude high fibrosis or cirrhosis. APRI NAFLD fibrosis score, I will come down to that. What are these scores and whether you can use them bedside or in your clinic or not. But as I said, metabolic syndrome is very, very important. Alone diabetes or any component or more the components of metabolic syndrome, I think more are the chances of having severe liver disease. So I think always look, and this is, this is possible at even the remotest of the areas, I think, where you can look at the components of metabolic syndrome. I think the lipid profile would be available at almost all centers. Diabetes, hypertension, obviously you can look at this, and waist circumference obviously can be measured. So metabolic syndrome is very, very, easy to, look at this. So let me just tell you, this was only the one study which we had picked up about, as I said, the postmenopausal females would have, higher severity of disease. But then what is APRI? I mean, this is a very common, bedside tool which we use in our clinical practice, and we keep telling our residents on bedside to calculate APRI. And this you can do in your clinic, you can do on your computer, and you can do it on your mobile. So what you need is only AST value and the platelet value. So just put it on a computer. I think go to the app or go to the Google and just say APRI, and this will give you like this. Put in the score, AST value, say in a particular patient of 74, and the normal ALT level what we still take in India is 40, divided by the platelets in thousands. 2,70,000 becomes 271,000, right? So 270,000 you divide it, multiplied by 100, and the figure which you get is known as the APRI, which is the AST to platelet ratio index. Any value which is more than 1 is considered as suggestive of significant fibrosis. And if the value becomes more than 1.5 or 2, I think this is usually taken as suggestive of cirrhosis. So it's a very simple test. As I said, you can do it on your bedside. Another, online calculator which you can do again on your mobile or on your laptop is known as FIB4. FIB4, in addition to platelets and AST, you just need ALT and the age of the patient. Again, I think if the value is more than 3.25, it is again suggestive of, significant fibrosis or cirrhosis. I think, again, very simple tests. And then there's another online calculator, which they call it as NAFLD fibrosis score. For that, in addition to the platelets, AST, ALT, you need ABDOMEN, which is also very easy, age, BMI, and the diabetic status. So again, if the value is more than 0.675, again suggestive of significant fibrosis. So these are some of the simple bedside tests which I think you can very easily do. Categorize your patients, and then if they require any tertiary care help, I think you can send them for a liver biopsy. But the important I think thing which I thought would be available in most of these centers, big centers, at least in Ahmedabad and other places where people are watching us, would be some form of elastography, right? And the commonest form of elastography, what we use in our clinical practice, is known as FibroScan, which is, a transient elastography, or what we call the vibration controlled transient elastography, right? But then there are various other forms of elastography also available, which are, RF based or acoustic radiation force impulse, and they are usually with the ultrasonologists. So anybody who has a good ultrasound latest machine would also have a software for elastography. So when you send your patient for ultrasound, ask your ultrasonologist to also give you a shear wave elastography value, which is also comes in kilopascals, as comes the FibroScan value in kilopascals. So that will give you an idea about the degree of fibrosis. So that is very, very important, right? So again, FibroScan has been very well validated in patients with fatty liver disease, and it's a very good non-invasive marker for assessment of this thing. Finally, based on all these assessment non-invasive ones you have done, and you think that this patient could have NASH or could have a fibrotic NASH, I think ideally these patients should be subjected to a liver biopsy to confirm your diagnosis of fibrotic NASH. But then, as I said, in clinical practice, it may not always happen. For various reasons, the patient may not agree for a biopsy. You may not have a facility for doing a liver biopsy. And biopsy, is an invasive procedure, is not free of complications, can have pain, bleeding, even deaths have been reported, right? So always, categorize your patient. And many a times in clinical practice, you can take a decision of treating your patients even without liver biopsy also. So having said that, I think so I mean, this is a very common question which we ask our residents: what are the indications of doing liver biopsy in a patient with, say, fatty liver disease? So one indication I told you was that if anybody is suggestive of having a severe disease, which is NASH or fibrotic NASH, based on your metabolic syndrome and various other non-invasive assessment, would qualify for a liver biopsy. Other than that, if you have, any competing etiology, for example, as I said, if somebody is hepatitis B positive, hepatitis C positive, autoimmune markers positive, and you are not sure which disease is, causing how much of damage, ideally these are the candidates for liver biopsy. And in tertiary care centers, you have a lot of clinical trials which are going on. So it is the, requirement of the clinical trials to make a baseline liver biopsy, and then after the the trial is over, you do a second paired biopsy to look at that how much is the improvement which is happening. So these are some of the indications for liver biopsy. So before I go into maybe 10 minutes into the management of fatty liver disease, I would just like to present two very short cases which will help you in understanding the role of liver biopsy. And I think I still have around 10-15 minutes. Dr. Yogesh, can I take those? Okay. So this is a female who came, 35 years old female, known case of SLE, came to us with elevated ALT, right? And obviously when she came with the elevated ALT, you would do the whole workup. So the viral markers were done first, which were negative. And since she was SLE, raised ALT, the autoimmune markers were done, and she turned out to be ANA positive, anti-nuclear antibody positive. So the next step was to do an IgG levels, which were elevated. And so ultrasound was done, which showed a bright liver or hyperechoic fatty liver. Fibroscan was done, which was 8.4, and as I said, any value more than 8 we consider as significant fibrosis. So given this database, what would you think clinically? You would always think of autoimmune hepatitis as a possibility, because patient has an autoimmune disease, has elevated ALT, ANA is positive, IgG is elevated, but then as I said, ultrasound had shown fatty liver. So there is a confounder here. So always perform liver biopsies in these kind of settings. So we did a liver biopsy, and to our surprise, there was no evidence of autoimmune hepatitis. It was all NAFLD and some lobular inflammation and fat. And so it was all happening because of fatty liver disease, and there was no AIH. And had you not done biopsy, you would have, treated this lady with corticosteroids and with immunosuppression as AIH. So I think the biopsy is very, very important in these kind of situations. So let me again show you another case. So this is a 37 years male, again came with incidental elevation of liver enzymes, and on evaluation again as a first step, he was found to be hepatitis B positive, surface antigen positive. So again, whenever somebody surface antigen positive, the next step you always do it. I'm pretty sure there must have been some CME on chronic hepatitis B also. So E antigen you do it, which is negative, and the DNA you do it, which was very low. Any level of DNA less than 2000, we always take it as low, or we even call them as inactive, right? So this gentleman was thought to be having inactive B, right? Because the DNA was low. But the problem is, if it was inactive B, why the enzymes were elevated? I think that was the problem. So ultrasound was done, which showed fatty liver. So then it was thought that probably his B is inactive because his DNA is low, and his rise in transaminases is probably happening because of fatty liver disease. But again, there was a confounder here. So we went ahead, as I said, followed the stepwise approach. We did the fibroscan. The value came as 37 kilopascal. Can you imagine? I think any value which is more than 12.5 or 13 is taken as cirrhosis. So on fibroscan, there is a suggestion that he could be a cirrhotic. So we went ahead and did a liver biopsy, and biopsy showed cirrhosis, right? And it was thought that at 37 of his age, he's unlikely to have, cirrhosis because of NASH. So it was nothing but hepatitis B related cirrhosis. Then he was put on antivirals. Sometimes and many a times, I think you must have seen your cirrhotics who are hepatitis B, the DNA may not be high, right? The E antigen may be negative, just HbA1c positive, and they could be cirrhotic. So I think had you not done a fibroscan in this gentleman, had you not done a biopsy in this gentleman, I think you could have just passed it off as, fatty liver. Because he was a young, just a rise in transaminases, and you just thought incidental B, and then fatty liver would have gone on. So I think the stepwise approach is very, very important. So now finally 10-12 minutes on the management part of fatty liver disease. I think as we discussed that this is a metabolic disease which is related to metabolic syndrome. So you have to take care of all the metabolic risk factors which are present in these patients. Look at the risk factors. If it is diabetes, control your diabetes well, hypertension, dyslipidemia. And again, I think we'll come down to that. But if you want to use statins in these patients, they are absolutely safe. You can use that. I think even if though the enzymes are elevated, still I think there are a lot of data now, you can use that. As I said, control of risk factors is the first step. Exercise is a very, very important. So what kind of exercise, how much exercise, I'll show you in my next slide. But irrespective whether they are lean or whether they are obese, the exercise has been shown to improve insulin sensitivity, and we understand that insulin resistance is the central pathogenic mechanism both in lean and obese NASH, so they have to be advised exercise. And those who are overweight and obese, we have to tell them about the weight reduction. Now, how much weight reduction, how much exercise, let me just summarize in this slide. So the simple formula what we follow in our clinical practice is that anybody who comes to you in your OPD with NAFLD and has overweight or obesity, just look at his baseline body weight. And if it is, say, in this gentleman, what we are discussing today, case presentation, is 70 kg. So you just give them, and BMI was 24.8. So he was overweight. So you just give them a target of 10% weight reduction over a period of 6 months. So 10% of 70 is what? 7 kgs. So 7 kgs in 6 months becomes around 1 to 1.25 kg per month. So it's doable, right? So you just tell them 1 kg a month. I think that's good enough. Now the question is, how do they lose this weight? So the loss of weight has to happen initially by what we call the lifestyle modifications or lifestyle interventions. So two important lifestyle interventions are, as I said, exercise and reduction in your calorie intake. So exercise, normally what we advise our patients are what we call the aerobic exercises. Aerobic exercises means brisk walking, running, jogging, swimming, cycling. These are the kind of exercises which they need to do at least 45 minutes to 1 hour every day. If it is not possible every day, at least 5 days a week. And the exercise should not be a leisure exercise. It should increase their heart rate. They should be sweating. And we tell our patient that while you are doing exercise, you should not be able to talk on your phone. That should be the intensity of your exercise. And ideally, if you have to look at this, we call it as that you should be able to achieve 60 to 70% of your maximal heart rate. Now, how do you calculate a maximal heart rate? Simple formula is 220 minus your age. So if you are, say, 60 years of age, and 220 minus 60 becomes 160. So, and 60 to 70% of 160 would be somewhere around 120, 110 or something like that. So if you're able to achieve that much of heart rate while doing your exercise, that is considered as a good intensity exercise. You should be sweating. You should not be able to speak on phone or mobile phone while you are sweating. I think this is the kind of advice you can give to your patients. As far as the dietary restrictions are concerned, I think it's not only the fat which need to be restricted. It is both fats and carbohydrates which need to be restricted. And how much restriction you need to tell them is, just tell them that you reduce your calories by 1/3 or 30%. For example, again, the simple example is if somebody in a particular meal is taking 3 chapatis, what we use in, say, in North India, right? So you just ask them to cut down by 1 chapati, which means 1/3 calories are gone. Or you can tell them that overall in a day, 500 to 1000 kilocalories need to be cut in a particular day. So I think these are some of the simple things. I think we cannot get into the details of, lot of data on Mediterranean diet and various other stuff, but then you need to be practical. You need to tell your patient what is possible in your patient. 1/3 calorie reduction and the exercise, this combo, we have seen in our clinical practice. I think even though the patient is not able to lose weight, it is good enough to actually reduce their liver enzymes. Good enough to to even normalize their liver enzymes. It's very, very important. Again, there's some data which is coming up on the resistance exercises. I'll not go into the details, but again, if somebody is not able to do, for example, aerobic exercise, what do you do? So I think they can still do, resistance exercises sitting in their room. I think that kind of exercise has also been shown to be useful in patients with fatty liver disease. And there's very good data to say that if you lose weight, say of 5%, the inflammation improves. If you have 7% weight loss, NASH improves. And if you have more than 10% weight reduction, even the fibrosis, does improve in the liver. But the problem is that when you give these kind of targets, and the study which I just said that this much is the reduction, you will have improvement. Only less than 1/3 are able to lose 5% of the body weight. And when you look at the 10% body weight reduction, only less than 10% patients are able to lose 10% of the body weight. So it's difficult. It's easier to say that you lose weight, but very difficult when it comes to really weight reduction. So I think that is a problem. So people have gone on to the various other modalities of various using pharmacological drugs, which we don't recommend for fatty liver disease. And there's always a problem, even if they're able to lose weight, but there's a problem of what we call weight recidivism, which means they will tend to regain weight even if they lose it for initial 6 months. After that, they will tend to regain. So that sustainability is very, very important. Just a word about bariatric surgery. Those who are morbidly obese or anybody who has a indication for bariatric surgery as such, right, and is not able to lose weight by lifestyle interventions, and the bariatric surgery is indicated, can be done, but not as a primary indication for NASH. If it is otherwise indicated, you can do it, right? But you have to be very, very careful in your assessment of your patient that your patient should not be a cirrhotic, because subjecting a cirrhotic to a bariatric surgery can really be a problem. They can land up in problem. They can have decompensation post, surgery. And I think you need to be very, very careful. There are a lot of data which are available where people have realized that their patients are cirrhotics while doing bariatric surgery. They looked at the liver and they found that the liver is cirrhotic. I think they have gone ahead with surgery, and some of them have landed up in problems. So, but avoid surgery in cirrhotic, and it is kind of a contraindication in decompensated cirrhosis. But as I said, not as a primary indication for NASH, only if it is otherwise indicated. Again, I think area which is coming up now is, the endoscopic bariatric and metabolic therapy. Various kinds of, endoscopic devices are coming in, which are being used for weight reduction, right? But again, I think there is very limited data and there are no randomized control trials. Still, they are not recommended. But again, I think you must be knowing, and it may be happening in your city also. People do put in, various kinds of gastric balloons and various kinds of other, ESG and various other endoscopic modalities are done, for weight reduction. But then, as I said, as a primary modality for NASH, they are still not indicated. So finally, what are the drugs if you have to use? Drugs ideally should be used only in biopsy proven NASH. But then, as I said, biopsy, if not possible in all, you can still use if your non-invasive assessment is suggesting you that, yes, this patient is likely to have NASH or fibrotic NASH. And the two drugs which were, recommended till recently by most of the societies were pioglitazone and vitamin E. We don't use pioglitazone much often because of the various side effects, which are associated with this. And these recommendations had come based on, some of the clinical trials. And one of them was this, what we call the Prevalence trial. But the problem with vitamin E and pioglitazone, as I said, is pioglitazone is not free of side effects. Even there are some concerns with the safety of vitamin E also. And there are problems that they may not be recommended in cirrhotics, but now the data is coming in. So a new molecule which is now available is saroglitazar. And this molecule this year early has now been approved for usage of patients with NASH, with F1 to F3 fibrosis, which is not amounting to cirrhosis. And this is, we know, is as a PPAR alpha and a gamma dual agonist, and probably you would know better than me because this drug first came for the usage in patients with diabetic dyslipidemia. And this is in market for almost now 8 to 10 years. Safe drug. But then, as I said, when people were using it for, diabetic dyslipidemia, they found that the liver enzymes were, also improving. Because of that, I think it started being used in patients with NASH also. And now you have a lot of good phase 2 data. And this is a phase 3 data, which was an around 10 center, study, which was conducted in India, histology based. And the results were presented early this year in the Asian Pacific Association for Study of Liver. And what it showed was that in comparison to placebo, which was around 23%, the reduction in NAFLD activity score, which is, nothing but the liver inflammation, was 52% in the saroglitazar group. And based on these results, the DCGI, the Drug Controller General of India, has approved this drug for usage in patients with NASH for F1 to F3 fibrosis is there. So again, I think a word about, what are the new drugs which are there in pipeline may not be really relevant to you, but I think one drug which is available now in Indian market for a condition called PBC, or primary biliary cholangitis, we call it. Earlier it was primary biliary cirrhosis. So this is obeticholic acid, right? But then it has still not been approved for usage in patients with NASH, though the interim data of this trial, which is known as a regenerate trial, has shown that it is much better than placebo in improving inflammation and fibrosis. But then the problem is that it is associated with a lot of side effects. And the important side effect is the pruritus, which can be seen in around 50% of the people, and the dyslipidemia, increase in cholesterol and LDL cholesterol, and reduction in HDL cholesterol, which is a problem. So based on the limited efficacy and the side effects, the FDA in US has still put this drug on hold and has not approved for patients with NASH. As I said, it is available in the market, but it should be an off-label use if you're using it for patients with NASH. Some of these patients with NASH may turn out to be having cirrhosis. For them, I think the time doesn't permit me to get into the details, how to manage the cirrhosis and the HCC if they have. I think we can have maybe discussion on this. But some of the drugs, vitamin E data and metformin is coming up, where people have started using them in cirrhotics, and where they have found that it reduces their decompensation rate, reduces their requirement of transplantation, and reduces their HCC. But as I said, time doesn't permit me to get into the details. But yes, we do have certain drugs. And the obeticholic acid, which we just discussed, this is also a trial which is known as a reverse trial. This has been completed in cirrhotics. So let's wait for the results, that how did it work in cirrhotics, and then tomorrow, as I said, this molecule is available, whether we can use this in cirrhotic or not. This is one thing which I said in the beginning: don't look at the liver only. NAFLD is a multi-system disease. It's a part and parcel of metabolic syndrome. Always look for other, look at the heart of the patient, cardiovascular, look at the kidneys. These patients are more prone to CKD. Look at the bones. These patients are more prone to osteoporosis, extrahepatic malignancies, more of diabetes. I think so that needs to be kept in mind. I think this question would come up in discussion, that whether they should be allowed to take alcohol. No. So I think any amount of alcohol should not be allowed in these patients. And statins, as I said, are safe in these patients if they are indicated for elevated liver enzymes because of dyslipidemia. So let me summarize now. This is my last slide. That I told you in last, maybe 40-50 minutes, is that there's an ongoing debate about the changing terminology of NAFLD versus MAFLD, but there are a lot of deficiencies even with the MAFLD. So till today and tomorrow, till it is accepted, we have to still use NAFLD or non-alcoholic fatty liver disease as the standard terminology. It's a kind of epidemic in India also. I think, as I showed you, the figures are as high as 25 to 50%. But important is that the NASH or fibrotic NASH is also very common. So I think we need to realize, and for that, it is very important to have what we call the stepwise approach. So you must exclude alcohol, other causes, look at the metabolic syndrome, look at the other causes of rise in transaminases, look at the severity, and try to, categorize your patient, whether that patient has got NASH, and if yes, whether it's a fibrotic NASH, and a lot of, non-invasive assessment you can do for fibrosis at least. Biopsy only in select situations in tertiary care centers, and standard of care for all of them, as I said, exercise for all, whether lean or obese, control of metabolic risk factors for all, and weight reduction for those who are overweight and obese. How much weight reduction, how to do that, I think that we have all discussed. Drugs, right now in the Indian market, you have at least 2 molecules which you can use, but only if you have confirmed NASH, F1 to F3 biopsy proven, or it is a presumed NASH on your non-invasive assessment, vitamin E and saroglitazar. And there are a lot of new drugs, as I said, in the pipeline, and one of them which is likely to approved maybe in soon would be obeticholic acid, but till now it is still not approved. Management of cirrhosis and HCC, as I said, remains the same. The time doesn't permit me to go into the detail, but remember that NAFLD is a multisystemic disease. Don't only focus on the liver, look at the other systems also. So thank you very much for your kind attention, and let me now stop sharing my screen, and then maybe we can have some discussion. Thank you very much.
Thank you, Dr. Ajay Duseja, for a nice and lucid talk on this very, very neglected topic as far as management is concerned. You have very, very nicely narrated about basics of NAFLD, what is the exact probable mechanism, what can be the clinical features and clinical manifestation, how we can diagnose, what are the diagnostic criteria, how should we approach this patient. We have also mentioned about the latest study about diagnostic criteria, as well as what can be the therapeutic approach we have to do for, and we have nice mentioned about our Indian molecule cirrhosis also. So it's a very, very informative talk on non-alcoholic fatty liver disease. We have I'm Dr. Ajay Prajapati and my colleague Dr. Maulik Kilaiwala. We are practicing in Ahmedabad and diabetes and metabolic physician. So
Right.
whenever we look at the patients, this big bunch of the body profile, it's a usual tendency that we neglect the grade 1 fatty liver. So it's a part of the system, or patient बहुत खाता है, चलता नहीं है, he's taking a little bit alcohol. So it's a neglected subject as far as the body profile is concerned. So ideally we have to go in detail, and we have to search the exact etiology, and we have to guide the patient so we can prevent further progression of liver disease as well as cirrhosis. Wonderful, Dr. Ajay Duseja. And we have a good question about this small topics. And one thing that the insulin resistance is early, or fatty liver is early. Insulin resistance is one cause of fatty liver, and fatty liver can create insulin resistance. So what should be the first?
I think that's a very, very important question, and a very pertinent question, I would say. This is always, this is an ongoing debate till the onset of this entity, what we call the chicken and egg phenomena, right? So whether the fatty liver comes first and that leads on to insulin resistance and metabolic, syndrome, or it is the metabolic syndrome and the insulin resistance which comes first, and that leads on to the fatty liver. So this is, as I said, now, but the present consensus, and to be little short, is people now believe that this is a bidirectional phenomenon. Both way it is possible. I think there are a lot of data, cross-sectional and the longitudinal data which is available to show that if you have fatty liver and if you do not have insulin resistance and no diabetes, over a period of 10 years, there's good very data available that people would tend to develop insulin resistance and tend to develop diabetes. So NAFLD is considered as a risk factor for a long-term risk of your diabetes. So I think that is thereby suggesting that fatty liver without insulin resistance can lead on to insulin resistance or diabetes. The other way around, as I said, is also, a lot of data that if you have diabetes or insulin resistance, your risk of having fatty liver disease is obviously more. So I think, to put it short, it's a bidirectional phenomena, and both way it is possible.
Sir,
Another question from Dr. Vimal Sardava from Rajkot. Young male, occasionally alcoholic, shear wave elastography says the mild fibrosis 9 kPa, SGPT, SGOT ratio is a little bit 2 times higher. Is there any need of a biopsy, or we should start the treatment, seroglitazar or any other molecule, sir?
See, as I said, alcohol obviously needs to be excluded. There are again certain scores because of the paucity of time. I did not go into the details how to differentiate it from a pure NAFLD versus alcohol versus a combination. But then if you have excluded significant alcohol intake and you think this is a non-alcoholic fatty liver disease and there is a rise in transaminases and you have excluded all other reasons for transaminases, which I have alluded to in my talk, and you think that patient has got significant fibrosis, which is evident by the fibroscan or elastography value of 8 or more, you can call it as fibrotic NASH, right? And if you do not have the facility for liver biopsy, or if the patient is not willing to undergo liver biopsy, you can take a decision of putting him on pharmacotherapy. So that pharmacotherapy, as I said, are basically two: vitamin E or saroglitazar, depending upon your choice and availability. If the patient has diabetic dyslipidemia, your case for saroglitazar becomes stronger. But if there's no diabetic dyslipidemia, you can choose either of the two.
Okay. Sir, you rightly mentioned in your speech that NASH is a non-alcoholic fatty liver disease. It's just histopathological diagnosis. So before starting a saroglitazar, if we want to start, whether we should confirm by liver biopsy or we can start by just looking at a fibroscan.
As I said, I think the ideally is liver biopsy, and
Okay.
and the phase 3 study which we just concluded and presented, and they're all based on biopsy. Most of the clinical trials would do that, but the problem comes is in clinical practice it may not be possible to subject all your patients to liver biopsy.
Agree.
So many a times you have to take a decision based on non-invasive assessment.
Agree, sir. One patient comes to us with a body profile showing a grade 1 fatty liver, and he's taking a occasional alcoholic. If he asks us a question that which form of alcohol can I take that least harmful for my liver, so what should be the answer, sir?
I think in short, I think any amount of alcohol or any type of alcohol is bad. Right.
Okay.
So there's nothing which is safe. I mean, people would talk about red wine and, you know, the kind of constituents it has, resveratrol and others, which could be hepatoprotective. But, you know, initially, I think you may be looking for some protection, but in long term, you know, alcohol can affect various other systems. So you may be trying to, you know, protect one system. People talk about, you know, cardiovascular protection because of alcohol, but then you may be trying to protect your cardiovascular and maybe harming your other system. So as a physician, I think we should discourage or we should tell them no alcohol of any kind is permitted. If you already have a, you know, there's also a phenomena called what we call entity which came in, which is probably not going off after the NAFLD is coming in, is BASH. BASH is both alcoholic and non-alcoholic steatohepatitis. And this we see very common in our clinical practice, that patient is taking alcohol, is also obese, is also diabetic. So there's a, you know, two-way injury which is going on. Alcohol is also causing injury and the metabolic risk factors are also causing injury. So at least which are preventable, do that, no alcohol.
Agree. Another question from the Dr. Nandlal Sarda from Ahmedabad. Non-alcoholic patient with hepatitis B has a fatty liver. What should be the line of treatment? What is the prognosis for this patient?
Absolutely. I think this is again a very common scenario, and sorry, I did present a case on this.
Yes,
so,
yes,
you know,
we have a wonderful discussion on hepatitis B patients. Wonderful discussion.
So, you know, this is a very, fatty liver is so common. As I said, 30-50% of the people would have fatty liver. And then, especially if they have elevated liver enzymes, you have to obviously work them for other causes, and some of them would turn out to be hepatitis B positive. Even though the ALT is normal, it is our routine practice to always screen for viral markers, hepatitis B and C. So if somebody is hepatitis B positive and has fatty liver, you have to do workup for both the disease entities, which means for hepatitis B, you have to look at whether it's a replicating virus or it is an inactive virus. And for replicating, the two markers which we are done is the HBe antigen and HBV DNA. So depending upon that, you will assess whether the virus is replicating or not. And based on that, you will decide whether somebody needs treatment for hepatitis B or not. And the other thing which we always look at is the ALT level. So if ALT is elevated, E antigen positive or negative, high DNA is an entry point for treatment for hepatitis B. Now, in addition, whether there is a fatty liver is there, which as I said is very common, which may or may be contributing towards your, elevation of liver enzymes. And if you're not sure whether the elevation of liver enzymes is happening because of hepatitis B or because of NAFLD, these are the ideal candidates for liver biopsy. And to tell you the truth, some of these patients, we have subjected them to liver biopsy. And what we have found is that the cause of elevated ALT was not hepatitis B. It was NASH. Why? Because on biopsy, you can differentiate whether the disease is portal injury, what we call the zone 1, which is because of virus, or is it because of fat, which is zone 3, or a centrizonal lobular injury. So on that basis, you can differentiate. And if you think that the elevation in ALT is happening not because of hepatitis B, you may not even treat B. So, it would require, that kind of workup.
Okay, sir. This is a common question from Dr. Harish from Nadia, Dr. Anurag Sharma, Dr. Silence, Dr. Apurva Srivastav, that at all we want to treat the NAFLD. Then what should be the dose of saraglitazole, what should be the dose of vitamin E, and how long we should give that molecule?
Absolutely. I think that's a very practical question. So first, let me tell about vitamin E. Vitamin E is available again and now in India of 2 forms, but the major form which is available is the tocopherol, what we call, and the dosage which comes is usually 400 international units, 1 capsule. So the dosage which was used in the classical landmark trial, what we call the PETIENT trial, was 400 international units twice a day for 96 weeks, which was almost 2 years. But then in clinical practice, we don't give it that long often. Normally, our practice is to give 400 international units twice a day, at least for 6 months, and then see the response, and then we decide whether we really want to continue or not. As far as the saroglitazar is concerned, the dose is once a day, 4 milligram. So 4 milligram once a day. And as I said, in the histology study, which we finished this year or presented, it was given for 1 year. So if you start saroglitazar in a particular patient, because of his fitting into your inclusions, 4 milligram a day, maybe for 1 year.
So would you recommend fibroscan for each and every patient who is coming with?
I know it's a difficult question. Depends on the availability. No, I mean, we work in a tertiary care center. So at our setup, any patient with, who works with fatty liver disease, or for that matter, hepatitis B or C, would be subjected to, fibroscan. And I think recently we analyzed in last, 5-10 years, we have done around 50,000, fibroscans. So, but then our practice in tertiary care would be different from, somebody who's sitting in another place and may not have accessibility to fibroscan. There, they can categorize their patient. And there is a good article again from we have a group called Go Asia, Gut and Obesity in Asia, which we work on fatty liver disease. So we have given what is known as a 2-step approach. 2-step approach is you first look at the other risk factors, right? It could be APRI, FIF4, which are very simple, or metabolic syndrome. And if you think that these are high, which are suggesting you that this patient could have fibrosis, only then subject him to fibroscan. Otherwise, you can, if your APRI is low, if your FIF4 is low, NFS is low, which are bedside tests, right? And there's no metabolic syndrome component, you can avoid doing a fibroscan.
Sir, may I extend the question regarding the
sure, please.
Insulin resistance? Because as you had rightly said, that insulin resistance is the cornerstone of fatty liver as well as the future diabetes. So right. They are going alongside all the time. Why not to lower the threshold for pioglitazone as well as GL2 inhibitor as well as SGL2 inhibitors in our therapeutic armamentarium for those who are having insulin resistance with fatty liver? So why not to lower the threshold of all these drugs like metformin, GLP analogs, even latest SGL2 right. inhibitors?
Yeah, I think I didn't realize that the predominant audience was I should have dwelled upon this, and I think it's a very good question. Yes. I must say. Why? Because, as we said that the pathogenic mechanism is insulin resistance. Yes. So why not target the metabolic target by using these so-called insulin sensitizing drugs? Yes. So let me just take a half a minute on this. So, initially the first drug which was, used was metformin. and it was used in a big way. We also published some work on metformin. There are other centers who have published, but the problem is that metformin in fatty liver disease, we always look for NASH, and NASH can be with or without fibrosis, right? So when somebody does a clinical trial, you are basically looking at the improvement in NASH resolution, they call it, or improvement in fibrosis. Unfortunately, none of the trials with the metformin showed any histological improvement. So it is not recommended for NASH, number one. Pioglitazone, as I said, is a PETIENT study, and there are other studies also, has shown improvement in histology. So pioglitazone is recommended. But as I said, in our clinical practice, we don't use it because of the various issues, which are predominantly the weight gain, the pedal edema, and the cardiac issues. So we don't find it to be, safer. And this is the experience with various other centers also. But some of the centers do use pioglitazone, and it is recommended, number two. Now, coming to the other two molecules, which are, again coming in a big way. One is the GLP-1 agonists. And there's a very good study, phase 2 study, which is known as a LEAN trial, which is a study by liraglutide. So liraglutide was used in that particular study, and they did a histological improvement, and that was a positive study. So because of that, they wanted to go to a phase 3 study, but now the company has decided not to test it with liraglutide, which is an injectable drug, has to be taken daily, right? So then they start this. Now they are exploring a possibility of semaglutide, which is also we know is a GLP-1 agonist. So semaglutide again is injectable, is available, and the oral is available. So first they were planning to look at the weekly semaglutide, and now they are also probably looking at the oral semaglutide also. So that data is still evolving. Semaglutide is a very good study in Lancet, I think last year, which has shown that it does improve a lot of body weight, right? So semaglutide is a very promising drug, and I think once this study is over, I think probably this will be one of the drugs which would be recommended for the treatment of NASH. Last molecule, SGLT2 inhibitors. Again, the data is evolving with all kind of gliflozins, the empagliflozin, the dapagliflozins. There's one trial from the Medanta group. They call it as E-LIFT trial. That was on the empagliflozin. But again, it was not a histology based. They only looked at the MR-PDFF, which is, MR, the proton density fraction, what we do use for hepatic steatosis. There they showed the reduction. So the gliflozins or the SGLT2 inhibitors do work, but the problem is, again, there's no good histological study. Same center has also come up with another study. They call it as D-LIFT trial, which is on a dapagliflozin, right? But as I said, it is again not based on histology. So in NASH, you need to have drugs which shows you histological improvement, right? Unless you have that, I think the recommendations will not come in. But they are very good, promising molecules. I must agree with you.
Sir, you mentioned one paper on vitamin E and metformin in cirrhotics.
Yes,
So,
okay. Yeah, let me.
would you recommend that it has to be started, because in all standard teachings, vitamin E is not recommended in cirrhotics.
Absolutely. Again, a very good
A,
question.
B, C, like.
Absolutely. I think very good question. The problem is, if you look at, cirrhotics, especially those who are compensated, say you do an ultrasound and you do a fibroscan and the value comes as say 13 or 14, and you are defining him as calling as NASH cirrhosis, what do you do other than the lifestyle intervention? So you didn't have any molecule which is approved for NASH cirrhosis. So these are the two studies which have come from Naga Chalasani's group from Indiana University, US. Naga Chalasani is a big man in fatty liver disease, and the ASLD guidelines, he's the first author in all of them. So what they did in their center was a retrospective analysis of around 200 odd patients, those who had high fibrosis or cirrhosis, and one group was getting vitamin E, the other group was not getting vitamin E. And when they analyzed their result, they found that the risk of, decompensation, requirement of transplantation was much lower in the group which received vitamin E. The second study, again from the same group, was on metformin, same kind of design. And again, one group getting metformin, other not getting metformin. And again, they showed that your disease transplant-free survival, your decompensation and HCC went down. So these are the two retrospective studies which have suggested the role of vitamin E and metformin in NASH cirrhosis. But as I said, we need some prospective good data to again, before we say that these are recommended. But let me confess that after these studies came in last year, in our clinical practice, I think we have started using vitamin E in our compensated cirrhotics also. And we have a now starting a randomized control trial on this molecule for cirrhotics.
Again, sir, this should be, as they are already cirrhotics, it should be 1 or it should be more.
The dose you are saying? I think probably we have signal, my signal,
or
your
only
signal.
for 6 months, or it should be more?
Oh, no. Obviously, it has to be more. So in that particular study, they had done it for 2 years, right? Only then that made the difference in, in the, as I said, transplant-free survival. And so it cannot be 6 months then. It has to be long, right?
So another question from doctor that in diabetic dyslipidemic patient on top of statin, if statin is not able to control the lipids, then whether it's a good choice to add seraglutazole, or we should not combine both?
Yeah, absolutely. I think there's no harm combining also, but then seraglutazole you start using, and if your lipids get controlled, your diabetes is fine, you can take off the statins then. I think that's absolutely fine. I think that's a very good indication. As I said, somebody having diabetic dyslipidemia, having NASH, I think seraglutazole makes a very strong case there.
Okay. Sir, another question from me that so many articles so that coffee is helpful in fatty liver. So what is your opinion, sir?
Again, I would say a very good question. I think, again, I didn't, because of the time, didn't get into the details. But coffee, again, a lot of good studies. But then if you look at those studies, none of them are, kind of the prospective studies, right? These are the studies which are, based on, where people have, looked at the coffee drinkers versus the non-coffee drinkers, and then looked at the hepatic fibrosis and NASH and HCC and cirrhosis and all, and they have found it to be useful. Again, and probably it is not possible really to do these kind of prospective studies also. And people have now come to even meta-analysis also showing that the coffee does work. So I think if somebody is a coffee lover, or even if he's not a lover, if he really wants to take a coffee, I think it's a good advice. But the point is we must take at least around 3 cups of coffee a day. Only then probably you will get the liver related benefit. If you're taking 1 cup of coffee a day and you're putting a lot of sugar into that, lot of milk into that, that will negate whole advantage of having a coffee. So coffee means coffee, no sugar, maybe no milk or very little milk, and as I said, maybe 3 cups a day, it can help. Liver, yes, there is very good data to say that it helps in improving liver fibrosis and fatty liver. Yes.
Dr. Hirwani, can we have another 2 questions, or we should end the session? If you can permit, I can ask 2 questions.
I think if it is comfortable for sir, if sir allows, we can go.
Dr.
No, absolutely
maybe
fine.
1 question, sir.
No, go ahead, please, go ahead.
Sir, Dr. Ajay Singh Rathod asking about, can we give a seraglutazole to the patient of infective hepatitis with NAFLD?
There's no hurry. If somebody is having, say, acute viral hepatitis, right, and the ultrasound you have done is showing you fatty liver, there's no hurry. Let the hepatitis settle down, right?
Okay. Okay,
let the hepatitis settle down, let him recover well. I think there's no hurry. See, the beauty of fatty liver disease is it really gives you time, right? Unless somebody is a decompensated disease because of NASH cirrhosis or HCC, where you need to hurry up. Otherwise, I think plain and simple NAFLD, there's no hurry in, starting the exercise or starting your drugs. I think just wait and watch. Be slow. Let the patient recover from acute viral hepatitis, and then you can take a call. Because your workup will be, hampered while the patient is having acute hepatitis. Your assessment and your interpretation of the workup would be, difficult while the patient is having acute hepatitis. Yeah.
Okay, sir. Dr. Apurva Srivastava is asking about what are the results of bariatric surgery on NASH?
I think I did touch upon that in my
Yes.
talk,
Yes,
but
sir.
then the, bariatric surgery per se is not indicated for treatment of NASH or NASH with fibrosis. But there are a lot of data, including meta-analysis and a lot of cohort studies which are available, where people have been subjected to bariatric surgery because of their, severe obesity. And what these studies have done is they had taken a baseline liver histology. Then after the bariatric surgery was done and people lost weight, they have taken a second biopsy, and there's a very good data to say that the liver histology does improve after they lose weight after bariatric surgery. But having said that, as I said, it's a big surgery, and of all the patients who are, requiring bariatric surgery, if you look at the data, who are the candidates for bariatric surgery, say if you take a cutoff of BMI of say 35, right? And all those who qualify for bariatric surgery, and if you look at the data, only 1% of them are actually subjected to bariatric surgery. 99% of them are not. Why? Various reasons. And major reasons are obviously the cost, the preference for surgery, morbidity, and the mortality which is associated with this surgery. It's not a very simple surgery, right? So I think it should not be advised, and there are no randomized controlled trials in NASH where people have shown that you do bariatric surgery in one group and in other you don't, and then you show. It's only the cohort data which is available. So not recommended as a primary modality for NASH, but yes, if it is otherwise indicated, you can do it.
Sir, what can be the role of ursodeoxycholic acid and silymarin in patient? Is there any definitive evidence is there, or we should avoid to use such molecule?
The short answer is there is no definite evidence.
Okay, sir, fine.
Because the placebo controlled studies are available and they have shown that they don't work better than placebo.
Okay, sir. Dr. Maulik, you have any question?
No, sir. I was just listening basically you and all the discussion. I think sir has covered everything basically in lucid manner. I think means since the 1.5 hour, we have basically known, we have basically come to know lot many untouched part basically as far as the NAFLD concerns, and sir has cleared almost all doubts regarding the basically NAFL. I think sir, we have learned from you also, and you have cleared all the doubts about the basically NAFL. I have only sir basically one question basically, and then we are going to close the session as per the after taking permission from Dr. Sarvani. Sir, suppose some patient having a the patient is having no history of diabetes, patient having dyslipidemia, and patient having NAFL. So sir, can we basically we have to use the saroglitazar, or suppose patient having dyslipidemia, so just can we go for the statin or saroglitazar both? If you want to give then both the drug you can give, or only one. What's your basically your experience and what's your comments?
So I think partially I did answer this earlier in the sense that in the study which was done on saroglitazar, patients whether they had dyslipidemia or diabetes, but for some exclusions on diabetes that they should not have been on drugs like other than metformin and the DPP4 inhibitors. So I think the trial was open to all kinds of this thing. So somebody could have dyslipidemia, there also you could use it, and somebody without dyslipidemia you could use it, and it was, as I said, found to be effective in overall. So your question, if somebody has dyslipidemia and if you want to choose a drug, I think saroglitazar would be a good drug, right? But then saroglitazar also comes with a cost, right? And if you just want to use statins, I think the statins would also be a good initial choice. So either of the two, but mind it, the statins are not a good drug for the improvement of NASH. Whereas saroglitazar is a good drug for the improvement of NASH. So you have to be very clear in your mind, what are you wanting to treat? Only the dyslipidemia or the liver disease? If you want to take the liver disease, statins have not been found to be useful. They have been good for dyslipidemia. So if your assessment says that patient has NASH, right, with or without fibrosis, then your choice should be saroglitazar.
Sir, one small question.
Yeah.
The relation of sarcopenia cause or effect wise, and second is, can we use any biomarkers like HSCRP to future predict because there is inflammation in the
absolutely
central vessel.
I think coming to your second part on HSCRP, if you look at my first slide, which was on NAFLD, right? So metabolic dysfunction associated fatty liver disease.
Yes.
So there what they have done is that if somebody is not obese, not a diabetic,
Yes.
right, and if you have to choose two metabolic risk factors, one of the risk factors is HSCRP.
Yes.
More than 2.5, I think they have taken, right? So if you have an inflammatory marker and any other metabolic risk factor, I think you can still make a diagnosis of metabolic dysfunction associated fatty liver disease. And regarding your question on sarcopenia, I think that is again a subject by itself, and that's very common in patients with chronic liver disease, especially with high fibrosis and cirrhosis.
Lean fat.
Right, so we recently again finished this work on cirrhotics, NASH related and others, and looked at the sarcopenia in them. Very common, so they may be obese, but when you look at their muscle mass, I think they are sarcopenic. And there is again data which is emerging up, which has said that sarcopenia could be one of the risk factors which is determining the severity of fatty liver disease. Right, so I think especially in high fibrosis and cirrhosis, you have to be very, very careful in assessing their sarcopenia. But the problem is, assessment tools are not available everywhere, right? And they are not very easy. So that's the problem here.
Yes, sir. If
so much.
there is,
I would
yes, Dr.
I
Irwan.
would like to congratulate you. This is for the first time among all 4 clinics. It has gone for more than 1.5 hours. Thank you so much. It was a very, very wonderful and an informative session, sir.
Thank you very much for the opportunity, and look forward to more such opportunities. And thank you all for active interaction and the questions. I really loved it. Thank you very much.
Thank you very much.
Thank you, sir.
Thank you.
Thank you all chairpersons and moderators. Thank you so much.
It's nice
Thank you,
discussion,
Dr.
sir.
Yogesh.
Thank you very much.
Thank you.
Thank you.
Thank you.
Okay, bye. Good night.
Good night.